All right, Artie, we're going to begin with the Rheumatology Year in Review. This is a different version of what we've done for many years as Rheumatology Roundup. Who made these slides, by the way?
Well, it's tougher this year because the presentations yesterday were so good, and they covered a ton of material that was hot this year. So we had to go in and take out a bunch of slides, the things that are already covered, and still there's some overlap. But there's been so much good this year that we've had. We're going to cover a broad array of topics. So if you have questions, send them in. We have the iPad right here, so that way we can answer a question before we go and change diseases, because we're going to be going all over the place.
Absolutely. All right.
Yeah. All right. So first, you see this is a analysis of select PsA. You've seen the select PsA data before, and this is a head-to-head trial of the Jakinib upadacitinib compared with adalimumab in patients with psoriatic arthritis. And what this sub-analysis looks at is the influence of patient characteristics, particularly focusing on sex at weeks 24 and 56. And what you can see is that there's actually greater improvements among men than there is among males than there are among females. Across the board with the different outcomes you see pretty much. And this is something we've seen before. We've seen this in ankylosing spondylitis. You see this in some cases in rheumatoid arthritis. We saw this in a sub-analysis from the secukinumab study published last year as well. And it's fairly consistent, and it's a little bit, we don't know what underlies this. Some of the patient-reported outcomes tend to start out being higher among females. The pain is generally reported as being higher, but that's not the entire explanation.
So when you look at the colors, the darker colors being the males, the lighter color, dark green versus lighter green being females, it is consistent. It's across the board, except for maybe the skin responses. But this has been seen in other spondyloarthritis studies, other PsA studies. It's been seen in RA. It's been seen in other disease states as well, that women don't respond as well as men. And the question is why? Is there a pain component? Is a pain threshold issue? Or are there access issues? Or how the disease evolves in the different genders? We're going to devote in RheumNow the whole month of April to women in rheumatology, and one of the important topics that we're going to be discussing throughout the month is this issue of gender-specific responses in different diseases. Again, hopefully we'll shed some light on this. I don't know that we have a real firm grasp of this.
No, there are definite immunologic differences, which makes sense because the hormonal differences will, in animal models, certainly result in differences in the immune response, differences in the balance of the different subsets of T cells, difference in the array of M1 versus M2 macrophages, pro-inflammatory versus anti-inflammatory. We don't know if any of those are operative here, but it's a large enough difference that I think it's going to have to become more standard, certainly in PsA and definitely in AS, that you look at the data according to sex, just like we look at data now according to whether or not they're on methotrexate, because you want to account for any potential differences. And an imbalance in the sex distribution in groups could result in thinking one therapy was better than another. Here you see it's consistent across the different mechanisms of action. So certainly an important phenomenon we're going to have to pay attention to. All right, so this is Bimekizumab in psoriatic arthritis. So this is in the population of psoriatic arthritis patients that I think we're very interested in. That is the TNF incomplete responder. We like looking at people who are relatively naive to all treatment, but knowing that in many places the treatment algorithm calls for TNF to be the first biologic agent used. It's great to know how the agents will perform in there. So Bimekizumab is an antibody that blocks both IL-17A and IL-17F. It is a IL-17 inhibitor. Is it going to have different characteristics than the IL-17 inhibitors that we have available to us? And that we have to see. Yeah, if we could get to the next slide, what we'll see are very nice, very consistent data across the different aspects of the disease. Peripheral arthritis, well, let me go back one here. Peripheral arthritis, skin activity, enthesitis, dactylitis, really the whole array of outcomes that we see that we look for in psoriatic arthritis. One question is, well, a couple of things. One is, are the skin responses better? Some of our dermatology colleagues think that this might get you better skin responses. And these are, if you look at the PASI 90, that's an incredible response and a very high level of response. And of course, then the flip side. If something is stronger, that always sounds good, but is there any downside in terms of potential tolerability or efficacy? And one of the things that we've seen with the Bimekizumab is that in the dermatology studies in skin psoriasis, there have been more oral candidiasis with Bimekizumab than traditionally had been seen with other IL-17 inhibitors. So what is going to be the implication of that for us? I think rheumatologists, we don't like Candida. Maybe we don't put up with Candida as much as our derm colleagues do. But here it's really oral candidiasis more, and there's actually pretty good scientific rationale for why we shouldn't be worried necessarily about systemic candidiasis, which is why I think as internists we don't like the idea of Candida. But I think our derm colleagues say it's really more of a bothersome thing than something that's going to impact their treatment decision. Jack, what do you think?
So this has been approved. Has it been approved yet in psoriasis? Actually, it was put on hold by the FDA for a manufacturing issue. That's been resolved. It'll first be approved when it is approved in psoriasis, and then hopefully maybe sometime this year we'll see it in PsA. I think you're right. I think it's probably going to have a bigger initial splash amongst the derms where it's getting more buzz, and not surprising with those PASI 90 scores. This data was interesting because the same degree of response was seen in patients who were either TNF inexperienced or TNF experienced. So that's kind of comforting and a real plus for them. But will it make a splash in rheumatology remains to be seen. I think that, again, maybe more talk about IL-17s and their role will help, but is it going to, in fact, be better at the arthritis? From these data, it's hard to know, and we're not going to have head-to-head studies when this finally does get to the market.
Yeah, I mean, you really need a head-to-head study to make that kind of a call.
Right. So Be Complete, this is a study that came out last year that I think a lot of people in this PsA space thought was very interesting, in that it, albeit a small, less than 100 patient study, it was a trial of patients with PsA who were either treated with methotrexate alone or the combination of methotrexate plus leflunomide. One, we don't use a lot of combination therapy in PsA, and two, we seldom use leflunomide, and it's usually not included in discussions. But this data is really clear in showing a superiority in multiple measures of efficacy of the combination over methotrexate alone. And I have actually been using this for quite some time. We did the original methotrexate and leflunomide in RA studies, and that was always a good drug. And leflunomide worldwide is a very big drug and much more widely available than is a lot of the biologics that we have in the United States. So this is attractive data that could get put to good use, albeit still a small trial.
Yeah, it's funny, in the EULAR RA recommendations, they really don't like methotrexate plus leflunomide. They're very afraid of the combination as far as liver toxicity. But the liver toxicity you do see it a little bit more than you do with methotrexate monotherapy, but of course it's manageable if you stop the medication. And I think it can be actually a kind of a useful adjunct. If you had somebody who, for resource issues or whatever, was not a candidate for a targeted synthetic otherwise, even though leflunomide is not really, it's not as cheap as, it's not dirt cheap, not prednisone cheap. It's sort of an in-between. It's more expensive than methotrexate, but I think it's definitely an option. And here too, there were, as you see, it doesn't show them individually, but you see with MDA, which captures the diverse domains of psoriatic arthritis, that it was effective, and it can be effective in the skin. So this is kind of something to keep in your back pocket. We sort of forget about it when we talk to the fellows. Sometimes this hasn't occurred to them because they're not aware of the methotrexate leflunomide data in RA, but I think it's a nice combo.
There were more drug withdrawals for GI toxicity with the combination than methotrexate alone, so that is something that might be the downside of this.
All right, so this is an observational description, and this came from Spain, and it looked at the combination of biologic agents or biologics and targeted synthetic agents in spondyloarthritis. And this is anecdotal, but this was what has been happening in GI. And as we'll come to, in GI now we have controlled studies of combination biologic therapy. And this just shows that, the combinations, as you can imagine, vedolizumab plus TNF inhibitor is fairly common, but you see all sorts of other combinations of things that can work for the bowel and can work for the axial arthritis, and in different combinations of those. So there were a couple of serious AEs among the numbers of patients, but not very high, I don't think, given that these are the worst of the worst patients. And I think we do see patients for whom we're not fully successful with monotherapy, so this gives us a potential choice. So the next couple of slides are going to talk more about the idea of combination biologic therapy. Of course, remember the history was that we don't use biologic because of the studies of TNF inhibitor plus IL-1, so the tanacercept anakinra study in RA about 15 years ago, published by Mark Genovese, and also the TNF inhibitor, mostly etanercept plus the abatacept, published soon thereafter, where there was no added efficacy, but there was added toxicity. It was more serious infectious events. So that got the whole kibosh on biologic combination therapy that persists till this day. And I think we're finally going to come and maybe knock at the door and say, maybe there are some combinations that can be used.
Yeah, we were in that era, and I remember reviewing the animal data, which was very impressive. What it is, animal data, and the big surprise that it was not more efficacious but more toxic. As far as an SIE rate, which is 6%, which is not an incredible number, was higher than the control, which I think was about 2%. But I want to go back to the previous slide, which was an observational study. We do use combination expensive drugs, combination biologics sometimes. The one that wasn't on the list is one we often use, which is apremilast plus some other therapy in patients with psoriatic arthritis. And I must say, I sit in a lot of meetings where a lot of our colleagues say, yeah, I do it, and yeah, but no one really has any proof that this works. There's anecdotalism saying, really, I'm going to justify my choice of someone not responding to apremilast, and I add on a secukinumab or a TNF inhibitor or vice versa. I'm going to justify my choices by saying, well, I've kind of seen good things, but no one's got hard data to say that in fact works. But we need studies, and in fact, the studies are happening mainly in GI, and with the IL-23 inhibitor. And Janssen, who owns an IL-23 inhibitor and a TNF inhibitor, has done the Vega study, which has been presented. This is the Vega study in ulcerative colitis. This is a phase 2 trial that was presented previously. It's been published now, and you can see at the week 12 endpoint, using a GI ulcerative colitis outcome, that the combination on the far right was better than the two individual choices of guselkumab or golimumab in patients with ulcerative colitis. And you can see the good news on the table on the right is that there were no increase in serious infections or serious adverse events. So this is encouraging data. There are data. There's even was there some work going on in psoriatic arthritis with combinations?
There's a study, affinity, but it doesn't have all three arms like this does. This really shows you combo versus both mono together.
So this is, I think, encouraging data, and I think it opens the door for novel studies which need to be done because we do have refractory patients and we wonder if more aggressive therapy like this would work.
Yeah, this paper just came out, and it's worth looking if you have any interest in this. You could look at these and say, well, yeah, the combo is a little bit better, but if you look at the higher endpoints, so if you looked at, in GI, they have various definitions of remission they use in ulcerative colitis. There's clinical remission, there's endoscopic remission. At the higher levels of outcome, you see a bigger difference between combo therapy and the individual therapy. And also worth noting in this study design, the golimumab was used in the combo arm, but only through the 12-week part of the study. So they have going to have longer follow-up in which the people were only treated with guselkumab. So maybe addressing several issues here. Combo therapy, combo, and then going to mono. And I think the most encouraging thing of all is that we don't see a signal. Well, it's relatively small numbers of people, about 70 people in each group. You don't see a signal with toxicity. And I think that's always been it's great to have the efficacy, of course, and that says we should study it more, but the lack of additive toxicity, that's great. And I think that says we can, and maybe we can get to combinations of biologics or combinations with targeted synthetics, and maybe, we can do better for our patients with SPA, with PsA.
From those early trials, a combination of IL-1 plus TNF inhibitor, the FDA has been writing in the package inserts of multiple biologics that not to be used with other biologics. So if you're going down this path, you're clearly going, into uncharted waters and need to be aware of that and inform the patient of that. So a lot of excitement about lupus and new things in lupus, and I think that some of this stems from, this is actually more work from Dr. Fava at Hopkins, where he works with Michelle Petrie. They're very interested in lupus and lupus biomarkers. They did this study as a follow-up to their IL-16 study, which was a plenary session at ACR 2 years ago that showed that IL-16 levels in the urine were really correlated better with disease activity, with histologic damage, with many different outcomes, and superior to the things that you usually hang your hat on, which is the degree of proteinuria or complement depression and whatnot. In this study, they looked at a number of different possibilities and biomarkers, and you can see on the far right, the ones that were most predictive was CD206, CD183, and the UPCR really had, a high specificity and high sensitivity as far as biomarkers. And, again, this is a whole new era, and these are things that can be measured and might have real strong clinical applicability in the future.
Yeah, you never want to repeat kidney biopsies over and over again. And you do the biopsy, you kind of get an idea of what's going on in the kidney, and then how do you monitor how you're doing? And I think we do that poorly. So these would be very exciting, and I don't think anybody minds giving urine samples. So a biomarker based on urine samples, I'm really looking forward to seeing this being something that we may be able to take advantage of. There's so many times in the clinic when you really want to know what's going on in terms of the disease activity in the kidney.
So again, these did correlate with histology. And I think that's a really important point. I'm impressed by, in my travels, talking to many rheumatologists, academic centers, uniformly, a new lupus patient gets a renal biopsy. No questions asked. In practice, I'm not sure it happens so much. Show of hands in the audience. New lupus patient, do you always get a renal biopsy? Raise your hand.
Well, but new lupus patient who you suspect has renal disease? Or
well, let's say they have proteinuria. Let's say proteinuria or hematuria. Would you do a renal biopsy? Okay, so that's like 57%, would you say? Yeah.
0.3.
Okay. So again, the question is whether better data like this might avoid the invasive procedure. And again, it is a procedure that's fairly well tolerated with a very low risk if done well. But I think this is an evolving story. I think this is, especially this urinary biomarker story.
Yeah, this one, hydroxychloroquine levels. You heard Joel talk yesterday that use of the methotrexate polyglutamates was to see if patients are actually taking their methotrexate.
Right.
Is that the same story with this? So should we measure? You can get the hydroxychloroquine levels, and the level does correlate both with tolerability and with issues of toxicity. I don't know. I'm not really very sanguine about this.
Oh, I'm high on this. I think we should all do this. I think the numbers are, the absolute numbers when they're really below 500 and above 1,500 tell you the patient's not taking it or not taking enough or is possibly at higher risk. But, that target of 750 to 1,000 is important. But the other thing you need to know from this particular study was that patients who have renal impairment and stage 2 CKD or more had up to a 4-fold higher elevated levels of greater than 1,500. So you may have to adjust your target plasma levels of hydroxychloroquine in patients who have CKD. So there's a bit of an art to this. This is available, but most people are not doing it.
Wouldn't it be cheaper just to have their Apple Watch video them taking their Plaquenil pill? And if they're not taking their pill, then they're not taking the pill. You don't have to do a $200 test.
You're a big supporter of the Apple Watch, doing a lot of work in medicine. It's the digitally enhanced Apple Watch enhanced physician for the future. Again, if we could get measures like that in non-invasive ways, absolutely. And we'll probably go there, but it's going to take 20 years. In the meantime, remains to be seen how this catches on in rheumatology. The big study I think that a lot of people talked about was the Paisley study. We'll probably hear more about that in our next session on lupus. But quickly state that, JAK inhibitors have been tried in lupus. Baricitinib looked very good in phase 2, but failed in 2 phase 3 trials and was withdrawn for further development. And this is a new TYK2 inhibitor, and that's deucravacitinib. And their preliminary results in phase 2 look really good. The strange thing being, if you look at the bottom left figure, is with the standard primary endpoint of an SRI-4, it clearly was better, being on drug was clearly better than being on placebo, although it had this strange non-dose response, below the first dose, which was at 3 milligrams BID is the first dose, and that the 12 milligrams once a day being the darker figure was not much better, but significantly better than placebo. So there still remains to be, I think, further studies on this. Again, a lot of studies in phase 2 with lupus can look good, but not so good in phase 3. So we're really waiting to see what happens in the follow-up studies to this. But nonetheless, this is encouraging.
Yeah, it makes sense. The TYK2 is, of course, important in IL-12, IL-23 signaling, but it's also important for type 1 interferon. So it makes sense that it would be potentially useful in lupus. You really hate when there's not a dose response. It makes you wonder about what's going on. I guess you could make a case for it. And the other thing, and maybe Dr. Clooney will talk to us more, I love the alphabet soup of different outcomes that you have down the bottom, including the CLASI, though, which the CLASI has a nice separation, maybe the best separation, and that's just looking at cutaneous lupus, and it's maybe among the most straightforward outcomes of doing lupus. You do it like you do the PsA. You're told what to do and how much of the body, etc., and a nice separation for that. But as you said, you have to see the because things look good in phase 2 can fall apart in phase 3.
Yeah, I think more lupus trials should go after CLASI as a primary endpoint. It seems to, and isn't that not important to the patient? Skin and joints, and then build upon that. Because getting a drug approved for lupus has always been a very high hurdle with the endpoints that we currently have. We talked about this yesterday. Carol talked about Pexivas, the use of plasma exchange, and then alternate regimens of steroids in patients who have GPA and ANCA-associated vasculitis. This is a sub-analysis of the Pexivas study. And in this sub-analysis, which was 191 patients who had diffuse alveolar hemorrhage. They compared outcomes to those who had alveolar hemorrhage to those who didn't, whether they got Plex or not. And there was a clear-cut superiority in the Kaplan-Meier plot on the top right. The lowest line there are the ones who did not, who had severe diffuse alveolar hemorrhage and did not receive plasma exchange. So while some of these results looked to be different, there was a trend more so than actual statistical significance. I think a lot of people looked at this data and said this might be one of the situations where someone with severe diffuse alveolar hemorrhage, I would consider the use of plasma exchange.
Yeah, I think plasmapheresis divides the rheumatology community. You have your believers and your non-believers, and these data don't convince someone in either camp to switch camps, I don't think, because I would say I'm more of a believer in certain circumstances. And people in the ICU who have diffuse alveolar hemorrhage, you're throwing everything at them. You already threw high-dose steroids at them. You're throwing Cytoxan at them. You throw rituximab at them. But here you say, well, what about plasma exchange, where you're taking out the bad humors? I look at this graph and I would say, boy, if it's me, I think I'd vote for it. But I think people who are non-believers would say, well, no, it's not statistically better, and you have additional costs and potential side effects from adding in the plasma exchange. So I don't know. Were you going to get plasma exchange?
Absolutely. Me, my mother, and mother-in-law. I would be a believer in this data. So maybe the news this year in rheumatology for new drugs is the approval of the IL-6 inhibitor, Rheumatology and PMR. That was a recent thing. But there's been a lot of activity in treating GCA and PMR that Rob Spira reviewed yesterday, including the GACTA trial, the secukinumab and GCA. That was an interesting study from 2021 that we'll see more of, and the GM-CSF receptor monoclonal antibody also looked very good in GCA. There's a lot of development in this area, and I think that the question is, what will it take for us to adopt these therapies either in PMR or GCA? And Rob did review the data. What was your feeling about this? Are you yet to jump in on PMR with an IL-6 inhibitor?
I was very happy to see the approval, and I think that the data are way better, like Rob reviewed. For methotrexate, I'm not, again, dividing the rheumatology camp. I don't think methotrexate has a role in PMR, so I'm very happy to see the choices and very excited not only by the IL-6 but by the JAK inhibitors and maybe even by the IL-17 inhibition to have something. Now, of course, the people who get PMR are older, and therefore they start with more comorbidities, and you certainly have to take that into consideration with each of the agents that we're talking about. But not as if prednisone doesn't have side effects either. So I think the PMR data are very exciting this year. Really looking forward to being able to use it much more.
Okay, so things as far as new drug approvals, we did talk about, again, Sapphire. I didn't put that on the list, but in the last year we've had 2 new drugs for lupus, and that would be the voclosporin and anifrolumab, avacopan for ANCA-associated vasculitis, and then deucravacitinib has been approved for psoriasis. But there were many new indications for drugs already FDA approved for other reasons. So belimumab, the indication was extended from just lupus to lupus nephritis. Tocilizumab now for the ILD of systemic sclerosis. IVIG, a really important trial in New England Journal showing its efficacy in inflammatory myositis. Secukinumab extended its indications to juvenile PsA and enthesitis-related arthropathy. Tofacitinib in atopic dermatitis and AS. Risankizumab, the IL-23 inhibitor in PsA and Crohn's. Upadacitinib in PsA, AS, and atopic dermatitis. And baricitinib, in addition to COVID, was approved this year for alopecia areata and alopecia universalis. Methotrexate, we heard about yesterday, being used with pegloticase in treatment of refractory gout. Canakinumab was approved for Still's disease in adults. And rilonacept was approved for recurrent pericarditis, usually something seen by the cardiologist. There were some FDA problems. Tanezumab was its development was halted because the FDA rejected the application. Bimekizumab was halted temporarily for manufacturing issues, and that was resumed. So again, it was although the FDA had a fairly low year of new drug approvals and really no new arthritis drug approvals in 2022. All those were late 2021, actually. We're hopeful that more drug development is going to happen in the rheumatology space.
Do you think that if you go back, to me, you look at all the indications for the JAK inhibitors, it's really amazing. We write JAK inhibitors. The dermatologists are going to write JAK inhibitors, oral as well as topical. The GI people use JAK inhibitors. Do you think primary doctors are going to start to use them? They have so many indications now across a number of specialties. Is it going to be the point? I don't think many have written it yet, but is this going to be the tipping point for where internists may start writing for the JAK inhibitors?
I would have historically said no, because JAKs are being used for, RA and PsA and AS, and some talk about lupus, and now the anecdotal use is in macrophage activation syndrome and dermatomyositis, but now with the approval in atopic dermatitis, I think that now it becomes an entry-level drug, and they're going to start thinking, oh, this is like a statin or a quinolone, and start using it and once they understand that it's not just for atopic dermatitis, but for lupus and RA or whatever, I worry about where that could go.
Alopecia, and now you have vitiligo and prurigo nodularis. You have all these other things that you say that these might be effective in. I think you're right. I think we may see that the use of these may extend.
You keep tabs on your primary care docs. As John reviewed yesterday, it's going to be a banner year for biosimilars. There's 31 approved biosimilars by the FDA as of this year. 17 of those are in the rheumatology space, and most of you have had some experience with the infliximab biosimilars here in the United States, but this is going to expand greatly with now the availability of Amgevita, the biosimilar for adalimumab as of January, but in July, 6 more. And in September, 1 more are going to be approved as other adalimumab biosimilars. And the question is, what is this going to do to the marketplace? Will there be more people on biologics? Will we get into competition for the pricing of these adalimumab biologics? And the graph that John showed yesterday about how ultimately the pricing on infliximab biosimilars and the originator came down with more competition. So it'll be interesting to see what happens. I don't think there's been, even though we think this is a bit of a buzz, I haven't heard much buzz from the practicing rheumatologists about this yet.
Well, I've heard it from patients already. How many people, show of hands, how many people had their patient ask about this because they're told their prescription is going to be changed? No? Oh. Okay, wow. I've already heard this from several people, and I think it's only going to pick up.
Yeah, the downside of that, of course, is when the patient informs you before you inform the patient, it makes you look bad. This is like, what are you hiding from me, Dr. Kavanaugh? Why didn't you let me know this was going to happen, that they're out to get me and they're giving me the cheapy version of adalimumab?
No, since patients have brought it up, I've been telling, and if anybody's on Humira, I've been telling them, listen, you're probably going to be faced with this choice, and it's going to be, you can have the Humira, or you can have this one for zero copay. If you want the Humira, you're going to have the $100 copay. I
had a patient with infliximab. My hospital was making the decisions about which infliximab they were buying. And when the patient found out that they were not getting, the Remicade, that they were getting something else, they were so mad that I got thrown onto the junk pile, and they went across town to some other, Remicade prescribing rheumatologist, only to find out there that they're probably going to get a biosimilar as well. But again, this is as was mentioned several times yesterday, this is a communication issue that needs to be had with the patient. I think John's point about educating the patient goes a long way. And my strong belief is that patients are going to accept biosimilars if you accept biosimilars. I mean, if you believe in the data and that they truly are biosimilar, and that's the message you translate to your patients, they're going to be fine with it. But if you're like, Chicken Little about, I don't know, I wouldn't do it if it were me, or, then your patients are going to be adopting your behavior and your bias on this, and that just is going to make their management even more difficult. So we'll see where this goes.
And the data really don't support our worry, and there's data now. Really, the idea of them switching our medications, which can happen with the designation of interchangeability, or the concern about switch, which I don't think none of us are very comfortable with. But as far as the data go, it does not look as if it makes that much of a difference. You can switch, and that's been happening to our colleagues in Europe, certainly in the UK and Scandinavia. They've changed whatever version of the adalimumab or etanercept or infliximab. It just changes over time depending on the price, and despite it feeling uncomfortable, perhaps, there's no really scientific reason to push back.
For a number of years, Artie and I would go to Sweden every January. Great month to go to Sweden, by the way, and lecture there. And this is when they were adopting biosimilars. And the very first year, they were as nervous as we were. Like, we don't know how this is going to go. This is going to be really bad. And after that first year, the next 3 or 4 or 5 years, no problem. They were just very happy with it. The cost savings were great here. One of the points of this particular abstract is if you look at those two graphs, the one on the left, the red one, are people who previously had received the originator. So the originator experience, as opposed to ones on the right who did not receive the originator. And is that red a little bit better than the blue? It is. And it makes sense that someone who previously tolerated the originator drug switching to the biologic, they're sort of selected.
People who do well do well.
Brilliant. Yeah, that should be the title. So this was I think a big thing, and Kevin talked yesterday about all the exciting work being done in preclinical RA, the at-risk patients. This is a study that they did over time of patients, and really based on the studies that they have done supporting their mucosal hypothesis theory. The original studies were that patients who were first-degree relatives who were seropositive, when you looked at their lungs and did bronchoalveolar lavage, you had a lot of inflammation present in the lungs of patients who were just at risk, suggesting that maybe this is, that RA is starting, maybe even in the lung in these people. And there are other studies to support this, and we do know that CCP has actually been made in the lung. And in this particular study, what they were doing was they were collecting sputum samples and looking for multiple autoantibodies in the sputum, both CCP and rheumatoid factor, IgA, IgM, and IgG. And the bottom line is that they showed that if you had any sputum antibody that was positive, your odds of progressing from at risk to actually developing inflammatory arthritis were 4-fold higher. And this is just spit. Then of course it's not really just spit. They induce sputum with inhaling saline, as you would if you were getting a sputum sample for AFB, but getting sputum samples so they know it was coming from lung as opposed to just being in the saliva per se. But I thought that there was a lot of buzz about this as another way of maybe taking that person who comes in who's a first-degree relative, who's got a strong CCP positivity, and they have, he said 20 to 80, I say, 40 to 60% chance of progressing to RA. Do this test, and now the odds go up even higher. I'm going to follow them more closely.
Yeah, and maybe ask Dr. Dean to comment on anything that gets us to say which of that 20 to 30 or 40% of people is going to develop rheumatoid arthritis. So the separation that they saw with this, and as you said, not only is it seems relatively simple, and it fits with our hypotheses about the mucosal origins, perhaps, of exposure to etiologic factors. So this maybe this is something that we're doing on that patient, like we talked about on the cases that Kevin presented yesterday. Somebody comes in who's seropositive but has a mother with arthritis but has no arthritis yet. How do we approach that patient?
Kevin, are you here? Would you care to make a comment on this? I think this is really important enough that I'm bothering you to comment on your own research.
To one point, it is actually easy to do it. You nailed it. It's exactly like collecting an AFB where somebody gets some inhaled saline and coughs it up. So it's a well-approved, well-tolerated test to get this sample. It's a little finicky to get the lab to run it, so we're working on that, making that a smooth test to take sputum and now run these antibodies. But it's quite reproducible. So exactly as you said, we envision this, somebody who is at risk either by a blood test or family history, you would get this along with blood testing, and in combination can really select out the people who are at super high risk. It may also give us a window into precision medicine. If you're at risk for rheumatoid arthritis, why? Well, you're a lung mucosa person that might require special intervention versus somebody who might be a gut mucosal driver or some other thing. So more to come, but I think this is a nice way to improve our prediction as well as precisely identify how you're getting to RA and when we may target you differently if you have a lung generation.
Has anybody looked at saliva CCP?
Yes, saliva is tricky because it is probably more a direct reflection of blood because of the translocation. We did not put it in this abstract, but we've done a lot of careful work to make sure that sputum really is sputum and lung sourced, because we don't want to get confused by a saliva translocation, which basically tells you what's in your serum. So we want to make sure those are two separate things.
Excellent. Thank you so much. Again, we really like this research from ACR. Artie, this was about survival in RA improving over time. What do you think?
Yeah, maybe end with a feel-good message here. So we think we're doing so much better for our patients with rheumatoid arthritis, and I think we are. I think you know, if you see a patient now with episcleritis, you go and drag all the fellows and medical students in to see it. Rheumatoid nodules, it's sort of a teaching moment in the clinic. I think we are doing better, but we haven't had a tremendous amount of data that says that, yes, we are doing better. We have so many new therapies. We have new treatment strategies. So this was looking at all-cause mortality in Denmark. And, of course, they have a system to really adequately link rheumatoid arthritis with their death registries, so it's relatively complete data. And I think the message you could make with this is that if you look in older time periods, as we had always known, as we had learned for a very long time, that rheumatoid arthritis is associated with accelerated mortality. Ted Pincus was pushing this 30, 40 years ago. And if you compare the general population with the age-matched rheumatoid arthritis patient, you see that the rheumatoid arthritis patients had a higher mortality. What happens over time? Well, the advances in medicine help the general population, and longevity is increasing. And if you go now to the present time period in 2011, 2015, the general population has done better than they did in 1996 to 2000. But I think you could make the case that the incremental difference in the rheumatoid arthritis population has largely been obviated, and you see that we're much closer now to the general population. Now, what is that from? I think some of it has got to be our ability to treat rheumatoid arthritis better. Some of it, of course, is general medicine, the statins, the array of the better glycemic control, the approaches to cardiovascular disease otherwise. So the population has gotten better, but the rheumatoid population seems to be catching up, and that the increased mortality attributable to RA seems relatively smaller than it used to be.
Yeah, and it's not surprising that we're thinking that, gee, we're doing a whole lot better than we used to do, and we certainly are. We've changed the way we manage RA over these different time periods. That we're more aggressive. We continue to use a lot of biologics, and we're still doing better in spite of all the talk of weaning people off or lessening therapy. So this is for many years, if you looked at all the survival curves on RA, it never looked good. It always looked bad. It wasn't until Shireen Gabriel about 5 years ago showed that it looked like RA survival was improving in the modern era with modern treatment, and this is now sort of confirming that. So. Yeah.